I'm Shruti Patel. I am one of the GI medical oncologists at Stanford and the VA Palo Alto.
And I'm Tim Brown. I'm a GI medical oncologist out at UT Southwestern in Dallas, Texas.
Awesome. Okay, so Tim, ASCO-GI, we're highlighting Zolbetuximab, and there's some new trials, phase 2 trials that were reported this weekend. Where do you see Zolbetuximab fitting into the paradigm for esophageal and gastric cancer?
Yeah, it's a good question. So we have data from Spotlight and Glow that clearly show the benefit of adding zolbetuximab to chemotherapy to frontline setting of patients with upper GI cancers that express Claudin 18.2. The issue with zolbetuximab has always been the side effects, the nausea and the vomiting, and the relative lack of increased objective response rate as a payoff. What we saw at ASCO-GI was the presentation of Ilustra, which took patients who had Claudin 18.2 expressed at 50% or higher, and combined zolbetuximab with chemotherapy and nivolumab. Notably, in this study, there was no requirement for PD-L1 to be expressed. What we saw was really encouraging results, particularly in the patients that co-express Claudin 18.2 and PD-L1, with a PFS that was in excess of 23 months on the median. So I think that the next step for the inclusion of Claudin 18.2 in zolbetuximab is really going to hinge on the results of the SURNOW, which is going to be the phase 3 study that's going to test FOLFOX zolbetuximab nivolumab versus FOLFOX nivolumab in patients who are Claudin 18.2 expressing. I think really that's going to provide us a little bit more direction in how to best use this drug.
Yeah, I think something that we're all thinking about when we think about using zolbetuximab is the toxicity, especially with our patients with upper GI cancers. They present with dysphagia, some nausea, and so adding the nivolumab, to our chemo backbone plus the zolbetuximab and the time of the infusion. How do you think that might affect people kind of reaching for it?
Yeah, it's certainly the toxicity of zolbetuximab, the nausea and vomiting in patients who are already on average nutritionally compromised provides a lot of hesitance to use that drug clinically. The other thing to consider is when patients do have the acute nausea and vomiting, you have to extend the infusion. So you take what could be a 6-hour infusion, and you're turning it into a 10 or 12-hour infusion day. It's possible with the, combination chemotherapy, immunotherapy, and zolbetuximab, we see more responses, and perhaps with that, these patients are going to be less, nutritionally compromised, and so I'm really excited about these results. I think the phase 2 results are encouraging. It's not enough yet for me to induce, this, chemotherapy IO and zolbetuximab combination, but I am very optimistic for what the Lucerne trial is going to show in a couple of years.
Absolutely. I think Claudin 18.2 is we're all excited about it, and it's gonna change things in the future in some shape or form.
Yeah, I think what's real interesting about Claudin 18.2 is it might have the potential to be the first target for a CAR T study in patients with solid tumors. We did have the data that was presented at ASCO from Satricel out in China, which showed that it was pretty well tolerated and you can improve overall survival using a CAR T construct that targets Claudin 18.2. So I think it's a very intriguing target. I think the story is still unfolding, and we'll see in the next couple of years where it goes.
Absolutely. Thank you.